Okay, good morning. Hope everybody's doing well this morning. So this is an introduction to hemodynamic monitoring. I'm Chuck, and it's good to be with you all this morning. So we're going to talk about hemodynamic monitoring. And again, maybe most importantly, we want to talk about what it all means. So hemodynamic monitoring and transport is something that was commonly done for really sick folks some years back. It is not done nearly as often now. We'll talk about the indications, contraindications, some of the different advantages. We'll talk about troubleshooting, and in some cases we'll talk about how this would affect your therapy and transport. But most importantly, really we want to talk about the whys. Why in the world would you ever do something so invasive? And what in the world does this information tell you? So by definition, what is a hemodynamic monitor? Well, it's the study of the motion of blood through the body. And why it's important to you is that it helps you in early detection, very early in some cases, as the pathology is actually occurring in the patient. It allows you to see life-threatening conditions. And let me just tell you right now, there's a million people out there that'll tell you they're experts on hemodynamics. So it just kind of depends on who you talk to and what you're listening, who's sort of the definitive authority. But just know that when you need to hemodynamically monitor a patient, there is something life-threatening the matter with them, just by definition. So we begin at the beginning in defining cardiac output and the components of cardiac output, which, if you remember the formula, it's stroke volume times heart rate. So if you're going to change cardiac output, you have to affect either heart rate or stroke volume in order to directly affect cardiac output. Now, there is a definition, and whenever you do kind of advanced cardiology, it just drives you crazy because everybody has all of these abbreviations and medical jargon to throw at you. But stroke volume and left ventricular and diastolic volume are in fact the same term. So if you see LV, EDV, they're talking about stroke volume, okay? That's kind of what they're getting at. So things that we might alter or that may be altered in our patient that can affect heart rate, which is of course a component of cardiac output, are the parasympathetic and sympathetic side of the autonomic nervous system. The parasympathetic side kind of being the braking side and the sympathetic side being sort of the accelerator side. So again, those can drive the heart rate in compensation. They can also drive the heart rate in pathologic states as well. So then there's the stretch reflexes, the Bainbridge reflex is the most famous of the stretch reflexes in the great vessels. And then, of course, temperature hormones and then medications, which can block the body's response, such as beta blockers or medications that can accentuate a response, i.e. agonists, beta agonists, for example. And then the factors that alter stroke volume would be anything that affects preload. And Starling's law, of course, when we give a fluid bolus, every single time we give a fluid bolus, we're essentially counting on Starling's law, which is when we essentially stretch the venous side in increased venous return, we should theoretically put a mild stretch on the cardiovascular system. And therefore, on the preload side, we should also be able to put more pressure on the ventricle, i.e., increasing stroke volume and eventually supporting blood pressure. Remember that hormones also directly affect stroke volume, both in the conduction rate of the heart and in the ventricular output. And the sympathetic nervous system, again, as we said, acts sort of like an accelerator on the left ventricle. And then, of course, medications that are positive or negative inotropes can either increase contractile strength and forward flow or decrease. And then afterload, or the resistance that the ventricle has to overcome in order to eject its contents, also would play a direct role in altering stroke volume, either to increase or decrease. So some of the principles of blood pressure flow, remember the formula for blood pressure is cardiac output times total peripheral resistance, and total peripheral resistance is made of systole and diastole. Remember that the mean arterial pressure is actually the more accurate predictor of peripheral resistance, and it's essentially 2 times diastole plus systole divided by 3. Virtually all of our automated blood pressure devices will calculate this for us nowadays. So this isn't as big a deal to calculate as it once was, but mean arterial pressure is a much better reflection of peripheral resistance than is systolic pressure. So, and of course, sort of the classic non-invasive hemodynamic monitoring components are pulse rate and quality, a manual blood pressure, or capillary refill times. Again, much more accurate in younger people than in older folks, but still we use it. Urine output of greater than 30 cc's an hour. We know that if the kidneys are being perfused, that's a good thing. When they're not being perfused, you suspect a shock state, and of course, level of consciousness in adults, because again, blood, when a perfusion deficit occurs, the brain is the organ that usually shows it in the adult world first. So the question always comes up, can't we just rely on the non-invasive monitoring systems that we've used, to manage patients? And the answer is most of the time, 90% of the time, 95% of the time, actually probably more than that, non-invasive monitoring is very accurate. And so it is a good thing to use, and we use it in most patients. The reason invasive monitoring is there, and the reason that we have it in our protocols and we have it on our aircraft and we practice so often with this stuff, is that it's by far the most accurate measurement. It allows you, maybe most importantly, continual measurement, the second bulleted point here. And maybe the most important thing is you can measure really low readings, particularly blood pressure, particularly systolic pressures that get down and stay down below 70. It is exceptionally difficult to get a peripheral pressure and a non-invasive pressure that's accurate when blood pressures get that low, especially when you start giving some of your alpha agonists like levofed or vasopressin or neosynephrine. They squeeze the periphery so hard. They squeeze on the venous side, but they also squeeze on the arterial side, so that measuring a peripheral blood pressure essentially becomes not possible. Even if you get one, it's not going to be accurate. So, when you're giving alpha agonists for any great length of time, the reality is to get an accurate blood pressure, you almost are required to have an invasive monitoring, especially if you're going to have the patient for any length of time. And then, of course, the ability to administer medications through a SWANS, and again, also through a SWANS, the ability to decrease the number of venopunctures on the patient. All of these are indications and reasons that we would use invasive monitoring. So we'll begin here by talking about an ART-line, an intra-arterial pressure monitoring system. This is supposed to be a funny, by the way. So why in the world would we use an ART-line? Well, if we're giving vasoactive drugs, patients had a major surgical procedure, they are in prolonged shock, hypertensive crisis, if you have monoballoon pump, they have to have an ART-line. If there's some pulmonary system compromise, acute hypotension, again, very commonly might be a reason for us to use an ART-line. If they've received thrombolytic therapy, if they've had some sort of hemorrhagic shock state, or again, my favorite is the bottom bullet point, any hemodynamic instability. Again, we talked about before, if you have a sustained hypotensive episode and you're having to squeeze them, especially if you're having to use multiple pressors, or if you're using anything that's an alpha agonist over a long period of time, if you're going to have to use it for more than 45 minutes to an hour, the probability is that you will begin not to be able to get peripheral blood pressures. And of course, that's a problem because you're going to have to titrate your medication to a blood pressure. And if you can't get one, then that's a serious problem in transport. So for that reason, an ART-line would be indicated. There are, of course, some contraindications. peripheral vascular disease, coagulopathies, or bleeding disorders. Again, if you put an art line in and they exsanguinate and die, that would be bad. Fibrinolytic use, infected or burned sites, or vascular graft sites, all of these are relative contraindications to the insertion of an art line. So the most common site of insertion by just an enormous amount is the radial artery. The least common insertion site by just an enormous amount is the dorsalis pedis. Actually, I haven't actually seen an art line put in there. I've only actually seen one in my career, and it was over 25 years ago. So yeah, the dorsalis pedis is virtually never used. The radial artery is almost always the one that's used nowadays. But you can use the fem, the brachial, or the axillary if you're in a real bind. So why is the radial artery by far the most common site? Well, it's really easy to get to and easy to identify. We don't muck up a wrist very often. If we do, we're probably in the wrong line of work. It's easy to cannulate, it's accessible, it's reasonably easy to immobilize with some degree of comfort, and the risk of distal vascular insufficiency is not high at all. There are some disadvantages. It is reasonably easy to injure the adjacent nerves. It does have a small intraluminal size, and so consequently you can get artifact. There is, of course, some potential for thrombus formation as well. And you know, sort of the classic Allen's test where you compress the radial and ulnar artery together. This should occlude all distal circulation. And after, you know, a period of seconds, you release the ulnar artery, and you should see, you should actually be able to witness then the return of color and pigmentation to the digits. Again, if you don't, then that, of course, is a negative finding, and that patient would not be able to tolerate an art line in that radial artery. So, again, you don't have the collateral circulation for it, so you would then just move to the other side. Again, Allen's test we do perform before we cannulate a radial artery. On the fem site, it is less likely to become kinked or damaged because it's in the femoral region. There's not a lot of complications with prolonged use. You're able to access this thing in really low shock states or in CPR states, and you can put a really big catheter in there. It's really hard to overshoot this thing because at the inguinal crease, the femoral artery dives down against the base of the pelvis, so it's really almost impossible to overshoot it. Some of the disadvantages, it's impossible also to immobilize this region. There is the possibility of embolus formation, and emboli that form here are very likely to return and hit some important structure. There is the possibility of a peritoneal, retroperitoneal hematoma if you were to blow through the vessel. And of course, the primary problem with the femoral site is that it is in the inguinal area, and the risk of infection is just enormously high. As a matter of fact, they're virtually all considered infected. So the brachial site was a reasonably common site at one time. It's actually very rare now. It is, of course, much larger than the radial artery. It's pretty easy to cannulate, and there's not a likelihood of vascular insufficiency, so Allen's testing is not required. It's really hard to immobilize the elbow. The median nerve is very close to the brachial site, and it's very easy to damage. And so if you had a patient with really terrible collateral circulation, you could actually end up with compromised blood flow to both radial and ulnar arteries. And of course, that is a very bad thing as well. And then the axillary site does not have a lot of complications with prolonged use. It is an option. Theoretically, you can use it in CPR states. There is considerable collateral flow, which is the reason at one time people talked about it a lot. The problem is that it's very difficult to cannulate. Again, you have to sort of gyrate the patient and gyrate the person doing the cannulation. There's the possibility of damage to the nerve on cannulation. And for that reason, you just almost never see this one done anymore. And then, of course, dorsalis pedis is very small. If you had no access in the upper extremities, theoretically, dual circulation of the foot should prevent vascular compromise. But of course, it's such a small gauge catheter, and it's so far removed from the heart that this is really a poor site for putting an art line in. The patient can't walk, you can't immobilize it. There is a risk of thrombus formation. You just don't see this one done anymore. The vessel is just tiny, very hard to cannulate, very far away from the heart. And again, boy, I'm going to say this, and someone's going to see one of these next week, but I haven't seen one in a million years. So again, this is not a good site. You really would prefer to cannulate some other vessel. So some of the components of an art line: a catheter, pressurized infusion bag, heparinized normal saline, a macro IV infusion set, a transducer cable, pressure tubing, stopcocks, and a sterile dressing. So remember, an art line is the high pressure side as opposed to the venous side, which we're normally used to cannulating. So consequently, it does have to be pressurized in order to overcome higher pressures associated with arterial perfusion. So you can actually see the art line in this little artist rendering here with the pressure bag and the transducer. Notice that we want the transducer at the same level of the catheter, or when all else fails, put it at the level of the right atria and zero it out. But again, you would want to use high pressure tubing, and obviously then you would hook the transducer up to your monitor so that you would be able to monitor the art line waveform. So things to consider in transport: you want to know, the length and insertion site. Make sure all connections are tightened. Remember, this is a really high pressure connection. So the pressure bag should be pumped up to 300 millimeters of mercury. You don't want air bubbles between the transducer and the patient on the arterial side. You can if you're here to air emboli. We don't worry about it as much on the venous side. On the arterial side, we do, and the pressure bag should be about 2 feet above the patient's head. So again, you do have to worry about leveling and zeroing the transducer with the insertion site, or again, when all else fails, you can zero it against the right atria. You can just put the transducer cable on their chest at the level of the right atria and tape it down. Remember that you do have to zero against hydrostatic and atmospheric pressures. There are two separate pressures that the machine has to calibrate itself against. So again, once the transducer is level, then you zero out on your machine in order essentially to equate these two pressures and produce a faithful finding of the arterial waveform on the screen of your monitor. So pretty straightforward, simple stuff here. So there are 5 components to an art line waveform. And again, remember, this is an electrical tracing, but it is important to remember you're not actually measuring electricity when you're looking at an art line. You're actually measuring a pressure waveform. And I know that seems like I'm beating a dead horse, but it is an important thing to remember that an art line is actually a pressure wave. So changes in the pressure wave are very significant, since that is systole for the patient. That is actually producing perfusion, downhill. So there's the anacrotic limb, the dicrotic notch, the dicrotic limb, end diastole, and systolic peak. And if you actually follow the tracing from left to right, that's kind of what you're supposed to be following. The most important arrow is that second one there from the left that points down to the dicrotic notch. The dicrotic notch obviously represents AV valve closure and really separates systole from diastole and allows you to look at the pressure waveform and have some idea where you are in the cardiac cycle. So, of course, there are calibrations that we can do. There's dynamic response testing, and this essentially allows any fluid-filled monitoring system to have a calibration so that we can say we faithfully reproduce the patient's pressure on the monitor. And this is what they call a square wave test. Again, similar to what you do on an EKG when you calibrate and you have the square box test. So again, as you can see on the art line tracing here, that's essentially a square wave test. And that just lets you know that the fidelity of your machine is accurate. You are, in fact, reproducing the pressure wave that's inside the patient. So dampened waveform. So there are things that do alter the waveform artificially. That's essentially the short man's, short bus version of damping. So anything that artificially changes the waveform, either over or under damping, change the waveform in such a way that they're no longer useful to you. They're either exaggerated in the case of an underdampened waveform, or they're muted in the case of an overdampened waveform. And either way, you no longer have a faithful. When you're talking about correcting an overdampened waveform, look for clots or air bubbles in your art line. Make sure that your tubing does not have an extension on it. Make sure it's less than 3 to 4 feet. Make sure that all your connections are tight and that you don't have a leak somewhere. And then check for kinks in the line, or make sure, with us transporting, make sure that the cot leg isn't actually on top of the art line, or that it isn't been folded over. In some cases, your boot may be on it, or someone else's. In the event that you have an underdampened signal, look for bubbles, and again, look for an extension on the tubing. These are the likely winners of the underdampened waveform. So some of the complications that commonly occur in transport: infection, air embolization, hemorrhage, vascular insufficiency, again, especially with peripheral sites, an accidental intraarterial drug injection, which, by the way, is a very bad thing. The body does not like medications to be delivered on the arterial side. Cerebral embolism, arterial spasms, and neuromuscular injury. Again, we definitely want to keep the art line still in a neutral position. Remember, you want to use sterile technique if you have to change the dressing. And of course, you're going to reassess early and often the site for bleeding, infection, neuromuscular injury, etc. So just kind of some common things to look out for when you're troubleshooting. Backup of blood in the tubing. You want to check the pressure gauge, check all your connections, and verify the stopcock is not halfway in between. Make sure it's in the closed position. It's pretty easy to do, by the way, to accidentally bump that darn thing and have it move positions on you. So if you have a system disconnect, you have to perform an occlusive maneuver over the insertion site, and then reconnect the system by flushing an interflow device. If you have an accidental decannulation, then you obviously have to apply pressure. Remember, this isn't going to be an arterial bleed on a patient who is hypotensive, almost certainly, or you wouldn't have an art line. So this is a real emergency. And remember that you have to apply the pressure for at least 20 minutes, probably much longer than that. And you may have to apply, pressure dressings, God only knows what else. So you have to stop the bleeding, though. That's the take-home point there. You have to stop the bleeding because an accidental decannulation in transport means that one of us probably accidentally did it. So there is, of course, an enormous increase in your blood pressure at that point in time. So when your trouble is shooting your art line, if you can't flush it, check the stopcock position, check the pressure of the bag, make sure it's at 300 millimeters of mercury. Again, check for tubing kinks. And then you can aspirate clots with a syringe near the site and check the position of the site, check to see if maybe they've moved, if it's not properly immobilized, if the joint position, if it's in the artery, if the hand maybe is flexed or extended, or if you have them splinted, if maybe the splint has come off and you need to resecure it. So you can, of course, draw samples from art lines. These are kind of just some steps to kind of help you if you need to do that. If you had to remove an art line in transport, the take-home point here is to make sure that you document when and how and why you did it, and that you did maintain pressure dressing over the site, again, because that is, of course, an arterial hemorrhaging event that's going to be occurring when you remove that. So again, make sure that you document very, very, very well. I would clearly recommend, if you're going to remove an art line in transport, that you actually talk to medical control as soon as it's practical, because that would be a really, really big deal. I can't actually come up with a good reason in my brain why we would do that. The patient already had an art line and we were removing it in transport. That's supposed to be funny, by the way. Sorry, sir, looking for another vein. All right. So let's talk about central venous lines. Central venous lines. So central venous lines have been around for a long time. They're essentially used for the administration of bloods, vasoactive drugs, for monitoring central venous pressures, or if you're going to use them to insert a pulmonary artery catheter for parenteral nutrition, for the insertion of a venous pacemaker, or if you just can't get peripheral access and if intraosseous access is contraindicated. So there are some contraindications, coagulopathies, thrombolytics, fibrinolytics, infections. If the patient's a high risk of pneumothorax, if they have severe vascular disease, or if they have a suspected vena cava injury, or if they're combative. Obviously, you do not want to put a central line in someone who's combative, as they might pull it out. Or if they have some sort of distorted anatomy that would make the insertion so risky that it's just not worth it. So some of the common sites of central venous access are subclavian, IJs, FEMS, or externally you could have an external jug or cephalic or basilic site. So remember, the central venous line is defined by where the tip of the catheter is, not the insertion site, which is one of the reasons that EJs are listed. I know a lot of you are probably saying, yeah, man, we've been doing EJs for years where I work, and they were, of course, very popular years ago before, intraosseous was so easy to do, back when we used to actually have to use those spinal needles and hemostats and drilling and all that crazy stuff we used to do. Good grief. I wish I'd invented that drill device, man. I'd be a rich man today. But EJs, as with all central venous cannulation, remember on the venous side, virtually all the vessels connect because they're going to eventually end up in the superior vena cava. That's kind of where they all want to go. So so consequently, EJs eventually turn into an IJ. So depending on the length of your catheter tip, that is technically a central line. So let's talk about the common central venous line, subclavian. It's really easy. It's easy to access. It's easy to maintain. It allows unrestricted neck and arm movement. It doesn't displace easily. It has a low incidence of thrombus formation. So some disadvantages: there is a risk of air emboli when it's inserted. It is possible to puncture the subclavian artery, which would be bad. You can accidentally drop a lung when you insert one. You can hit the phrenic nerve. It is possible to blast through the subclavian and tear into the trachea. It's also possible to get the common duct of the lymphatic portal system, and if the common duct is sheared or torn with a needle, that's going to be a clean kill almost every time. That's going to produce massive blood loss, and it'll be in the intrathoracic cavity, which again is very likely not going to be a survivable event for the patient. However, again, with a little bit of common good practice, you can avoid these things. So again, the subclavian is really one of the preferred sites. So as you look at this drawing, and those of you that have been to cadaver lab know that for subclavian insertion, our landmarks here are going to be the acromioclavicular joint over. Oh gosh, I didn't mean to do that. Sorry about that. I can't draw for some reason. But over here on the distal side, the acromioclavicular, and over here the suprasternal notch, and then we'll divide the clavicle into thirds. And you can see in the drawing here, they of course have the needle going directly in the subclavian vein, but you would actually you would palpate underneath the clavicle here, hence the term subclavian, below the clavicle. And then you would pass the needle in this direction towards the suprasternal notch, and you can see that you pretty much have to hit the subclavian vein there eventually. It is large. It doesn't move even in dead people. It's easy to cannulate. So IJs are there. They're easy to hit. They're short, direct pathway to the superior vena cava or the right atria. Catheter displacement is not common. And there is not a high likelihood of thrombus formation, and there is a lower incidence of arterial laceration and pneumothoraces than with a subclavian. There is the risk of air embolism. It is possible to lacerate the common carotid. By the way, Laceration of the common carotid is associated with virtual 100% death. You can tear the trachea, you can drop a lung, and it is possible on the left side to hit the common thoracic duct. And again, tearing the duct with a needle is going to produce really bad things, just like we said the common duct, if you hit it with a subclavian insertion, very bad things happen there as well. So that's going to be a bad thing. But IJs are reasonably easy. Again, you see the sternocleidomastoid muscle here. It actually bifurcates, and you can actually feel it on most patients. Now, you do have to turn the patient's head to the side, and you can see in that head of the sternocleidomastoid, that's actually where the IJ lives. So the EJ connects to the IJ here, and that's the reason we always say that EJs and IJs, it's difficult to actually separate them based on the length of your catheter, because many times they end up being placed in the same section of the vessel. But you want to insert the needle in the head of the sternocleidomastoid, and you're going to actually shoot down here for the nipple line. So you're shooting same side nipple line, and it should be somewhere around a 4 centimeter insertion of the needle before you hit the internal jugular. Easy to hit. You do have to manipulate the neck, so this is not a good not a good technique to use in someone that you think might have a spinal or neck injury or some sort of central neurologic CNS insult. But they are reasonably easy to do with just a little bit of practice. And then femoral cannulation is actually pretty easy. It's accessible. There's no risk of pneumothorax. If you pop a lung from a femoral vein insertion, we have a real problem with your anatomic reference points. That's supposed to be a joke, y'all. It's in the wee hours of the morning here, so I'm trying to be funny. So it is a small vessel. There is a really high risk of infection. Again, anytime you're in the inguinal area, the risk of infection is always kind of the issue. It's really hard to maintain sterility. Sometimes with obese folks, you actually have to move a lot of kind of stomach around. There is the risk of a pulmonary embolus, and dislodgement is possible if they're moving their legs. Again, all of those things are manageable, but for that reason, femoral veins are not, femoral vein cannulation for central venous lines are not as in vogue maybe as they once were. So your landmarks here are the symphysis pubis, the anterior superior iliac spine, and you divide that inguinal crease there into thirds. You can see the middle third is what you're shooting for. You want to be roughly 3 to 4 fingers breadth distal from that inguinal crease, and then you cannulate with your needle, and you're shooting for the umbilicus. So you start central and you kind of work your way out. It's a blind stick unless you have it, but there's mnemonic. You can see there it's listed. So it's nerve, artery, vein. It says empty space. Most folks would say elastin, nerve, artery, vein, elastin, and then lymphatics and ligaments going from central to peripheral. So if the patient has a pulse, of course, your artery becomes your vascular landmark, and you know that the vein should be just to the left or just away from the central portion of the body. There's where the vein should be living. But if the patient's in full arrest or in a shock state so that you're unable to palpate an artery, then again, it's just a blind stick. These were, when I was my years at CareFlight, these were kind of what we used in the days before intraosseous. So we used to do these all the time. These are reasonably easy to do, again, with just a little bit of practice. So another landmark, you see this muscle, I believe it's called the sartorius, the one that kind of crosses over the rectus abdominis and the muscles that make up your quadriceps. So that's kind of a landmark there. You can actually sort of feel it on most patients where it kind of makes that crossover there. That's kind of, again, where you want to kind of start thinking about your insertion site. And then, of course, external jugular, pretty easy. So not a lot to talk about on the EJs, except to remember one of the reasons EJs in the adult population are not used more commonly for central venous pressure monitoring is that the patients that we need to do this on are usually already in vascular collapse. And when the patient is in vascular collapse, EJs don't show up as well, so they're more difficult. And this, of course, in the pediatric world is where they are still very commonly used. And then, of course, the cephalic or basilic are at least theoretically possible. There is no risk of pneumothoraces or major bleeding. They're easy to control because you can get to them. They are difficult to locate in edematous or obese patients. These are smaller vessels, so you have to worry about venous spasms. Advancing the catheter can be hard, and displacement is actually really very common. So theoretically, remember the trick here with a central venous catheter is it doesn't really matter where you put it in. It matters where the tip of that catheter ends up. So if the tip of the catheter opens up into a central vessel, you can still actually transduce it and measure central venous pressure. And then, of course, peripherally inserted central catheters are inserted and then advanced, and they're, of course, designed to be left in over a long period of time. So, and then some patients have indwelling catheters with ports that we can access with gripper needles and the like. So again, if a patient has one of those, certainly we would want to use those to our advantage so that we do not have to continue sticking the patient over and over and over. So again, with central venous catheter lines, remember the trick is where the tip of the catheter is. When it opens up centrally, this should allow you to measure the pressure in the venous system at the point when it opens up into the right atria. And so when the tricuspid is open, this should allow you to measure something called central venous pressure, or the other name for it is right ventricular end diastolic pressure, RVEDP, which equates essentially with preload. It also has a correlation with left ventricular end diastolic pressure. The magic here is that the norms are reasonably low, somewhere between 2 and 8. This will drive you crazy because if you read 15 books, you'll see 15 different norms for central venous pressure. Just know that all of them are low. You'll see between 0 and 8. I saw a textbook recently that had 1 to 7, 2 to 6 is common, 0 to 6 is common. Just know that the norms for central venous pressure are low. So these are the central venous pressure waveforms. Again, you see that they're identifiable here. To me, CVP waveforms look very similar to like really fine VF, and that's actually how I would describe it, is sort of like fine VF. There is a correlation with the QRS complex on your ECG, but it's very difficult to read and transport. Just know that you do want to see undulations on your CVP and a number. Again, this is kind of showing you what the different waveforms on the CVP represent. Of course, we are not going to ask you to identify these in transport. We just want to know that you do trust the fidelity of the monitor and that the CVP number that you're reading is accurate. Remember that any venous access point that actually opens up, like if you have a high IV up in a biceps on the cephalic vein, you could theoretically transduce that, and it would, of course, give you theoretically CVP numbers here. So you can see that there is actually a bar graph on the side here that allows you to sort of come up kind of with the number. The CVP should be obtained where it aligns with the end of the QRS complex on the ECG tracing. That's essentially kind of where you would want to measure your CVP number. So it wouldn't be necessarily at the peak. It would be more down here at sort of at the trough of the waveform. Most important thing about central venous pressures is to know what they mean. And remember, central venous pressure essentially indicates that there's a volume deficit or not. Again, as fluid is returning from the venous system to the right side of the heart, this would allow you to measure absolute hypovolemia, relative hypovolemia, or vasodilation. And again, essentially, you would have either low numbers, meaning the patient has a volume deficit problem, or you would have normal or high numbers, which would mean you do not have a volume deficit problem at all. So that's kind of the take-home point. Really, it's all about volume deficit. Remember that patients that are on positive pressure may have elevated CVP numbers because of the interthoracic pressure changes. Remember that when we're breathing on our own, we create negative pressures, which pull outside ambient air down into our lungs. But when we're breathing for the patient, we actually create positive pressures that actually drive air into the alveoli, or the alveoli. The alveoli, listen to me, my Latin. But positive pressure ventilation not only drives air into the alveoli, it also displaces blood that lives in those capillary beds around the alveoli. So there is a fluid shift in the thoracic cavity when folks are on positive pressure, particularly when they're on for any length of time. Obviously, how do we fix these problems? When we look at the patient, we look at the underlying diagnosis, and then we design our treatment plan and transport in order to accommodate these things. So there's just kind of a couple of pretty easy sort of case studies here. Nothing particularly earth-shattering here to make you go home and study your brains out. But if you have a 29-year-old male presenting to the ED with a really low pressure, 74/50, heart rate of 118, respiratory rate of 40, has a skin that's flushed and cold to the touch and was bitten by 12 bees approximately 20 minutes ago, and you have a CVP reading of 1 when you drop your central line. So the likely winner here of this particular situation is a relative hypovolemic event, right, from anaphylaxis. In this case, we suspect that this patient's capillary beds are now leaking. So consequently, fluid is maybe in the container, but in the wrong space in the container. So time in order to support that patient's blood pressure. On the other hand, a 79-year-old with a 74/50 with a heart rate of 90, respiratory rate of 24, and she has a CVP of 15. While we know that a CVP of 1 in the previous case study is really very low, a CVP of 15 is not very low. It's actually high, isn't it? And she has all kinds of heart gallops here, bilateral ralls, weak peripheral pulses with 2+ pitting edema. So this patient actually does not have a fluid deficit, but in fact, actually is a fluid retainer, isn't she? She's actually in failure. So this would, of course, be a very different presentation. So probably actually even at a 74 systolic pressure, we would probably even call that going into cardiogenic shock, probably. So we don't actually have enough information to call that yet, but this is a 63-year-old with a blood pressure of 84/70, a heart rate of 60, and a CVP of 24. You have clear lungs, you have pansystolic murmurs of the left lower sternal border, and the patient has an inferior MI with tricuspid regurg due to papillary dysfunction from an inferior wall MI. So again, in this particular patient, we have a high central venous pressure, but we also don't necessarily like the fact that our patients doesn't have a lot going on in the compensatory side. And again, with that inferior wall MI, we believe that that systolic pressure is actually pretty low. With papillary dysfunction, we know that that's a surgical fix. There's not a medicine that we have that will fix that. And the CVP reading being high is probably also related to the inferior wall MI that we have occurring. So again, we want to, whatever changes on our numerics, we want to make sure that there's a patient condition that corresponds to that. Obviously, our standard assessment parameters, non-invasive hemodynamic monitoring status, of course, with end-tidal CO2 now, we also know that that's a real good predictor of who's in shock and who's not in shock. So we want to re-zero and re-level the transducer. If there's any question about the fidelity of our reading, check the monitor and tubing connections. Remember, the beautiful thing about central venous pressure monitoring is it is pretty easy. If you have that squiggly line and you're getting numbers, there's a high degree of probability that it's working. If not, obviously you would re-zero it. It is a straightforward tool. Remember, low numbers mean volume deficit, either absolute or relative. You look at the patient's condition to determine that, but that's an easy answer. You dump fluid in them, whatever fluid that you have. Again, if the number's high, you do not have a volume deficit to speak of. You may have a relative volume deficit, but you don't have a volume deficit to speak of in the venous side as well. So straightforward, easy to use stuff. And again, The take-home point being here, management of your sick folks. So Swan-Ganz catheters, or pulmonary artery catheters, we want to kind of begin at the beginning here and just remind folks that that a Swan-Ganz and a pulmonary artery catheter are the same thing. So in the same sense that an AMBU bag and a BVM are the same thing, a pulmonary artery catheter and a Swan-Ganz are the same thing. So like in the BVM world, AMBU was the first bag that was available. So a lot of us call them AMBU bags even today, even though AMBU is now one of the smaller bag valve mask manufacturing companies. Well, Swan-Ganz was the first pulmonary artery catheter that was around. So people call them Swan-Ganz catheters now, even though there's many other brands other than the Swan-Ganz brand. So, so pulmonary artery catheter and Swan-Ganz mean in fact the same thing. So this is just kind of some historical data. So in the late 20s, a guy named Forsman was the first to prove that a catheter could be advanced into the human heart for testing purposes. By the late 1960s, Dr. Jeremy Swan had a parachute catheter. About the same time, William Ganz developed a thermodilution method to measure cardiac output. He was actually putting temperature probes in there and putting cold water in there to measure forward flow. The two got together and in 1970 came up with something called the flow-directed balloon tip pulmonary artery catheter, and it was of course named after them, the Swan-Ganz catheter that we know today. So what in the world are pulmonary artery lines used for? And the basic idea here is that with pulmonary artery catheters, you're able in real time to look at 3 different components all together. You're able to look at cardiac output, you're able to look at the pump, you're able to look at CVP and wedge pressure, you're able to measure volume and effective volume, and then you're able to look at systemic vascular resistance or squeeze and measure that. So the idea is in really, really low shock states with the Swan-Ganz, you can actually see what's working, what's not working, and it should allow you to direct your therapy at the problem, whether it's a pump problem, whether it's a volume or relative volume problem, and whether it's a squeeze, lack of, or too much problem. That's essentially why pulmonary artery catheters are used. So these are some indications. Again, the most important one is the third one down there, shock of all types. So remember that pulmonary artery catheters, you have to kind of think of like you would Levophed. You don't put pulmonary artery catheters in patients that aren't sick. It just doesn't happen. One of the reasons they're not as popular now as they once were is that a lot of ICU intensivists will tell you that we tended to treat for perfection. Well, most of our patients don't live in perfection. We tend to way over-treat when we have these things in people. So consequently, they just don't use them like they once did. There are some contraindications: coags, prosthetic right heart valves, patients with endocardial pacemakers, severe vascular disease, pulmonary hypertension, or if you don't have anyone that can take care of them, notice financial responsibility. So what do you know about these things? They're expensive to put in and expensive to maintain. This is a picture of one. You can see there's a bunch of different components to them. There's the balloon tip. See that they have bands on them that allow you to kind of measure how deeply they're inserted. This is the PA distal line, the proximal injectate line, the balloon inflation port line, the right ventricular pacing and infusion port line, and then the computer connection, obviously, so you can actually monitor that on your screen. So again, it's a quad lumen catheter in 5 to 7 French sizes. It's somewhere between 110 and 150 centimeters long. When you're looking at the markings on the Swan, a wide band is 50 centimeters, a thin band is 10. So like, for example, if you have 1 wide and 2 thin, then that would essentially be a 70 centimeter insertion point. Again, reasonably straightforward here. The different colored ports kind of let you know where the opening into the body is with the Swan-Ganz properly placed. So the yellow port should open directly into the pulmonary artery. You should not put infusions or meds in there. The blue port opens to a lumen that's around 30 centimeters from the tip of the catheter, so the opening should lie within the right atria. You monitor right atrial pressures, CVP. You can give fluids. You can sample arterial blood. They can do injectate studies there, but you shouldn't put vasoactive meds through the blue port. The red port is the balloon, and it really is only used to inflate and wedge. That's all it's used for. It has a syringe that's actually attached that will hold between 0.8 and 1.5 cc's of air. And you're not ever supposed to try to remove that syringe and replace it with another one. It's that syringe is pre-measured for that particular balloon. I bring that up because that's actually been done before by transport crews, which is kind of unbelievable because it's actually, you actually have to break it to remove it. I just can't imagine why anyone would ever do that. But anyway, the thermistor port is yellow and red. Again, it's got a temperature sensitive wire there. And then the white and purple port is for your drug infusions, pacer wires. They terminate in the right atria and or right ventricle. So what are the things that pulmonary artery catheter measures? Well, pretty much everything. I mean, it just measures everything: cardiac output, cardiac index, wedge, pulmonary artery pressure, systemic vascular resistance, and central venous pressures. So pulmonary artery catheters, when they're inserted, are inserted through a cordis, again, through the internal jug or the subclavian vein, and it's a single lumen central venous catheter that the swan is threaded through. It's around 4 inches long, shaped like an L, has a diaphragm on it, and that's what one looks like. And of course, they're sutured down. You can see they're pretty big honking thing there. So this is, as the device is being inserted, these are the waveforms that you would see if you happen to be there when they were inserting the device. So you see when the tip of the balloon is in the right atria, you get, again, those CVP type readings. Then as the balloon tip is advanced into the right ventricle, you see you get something on the pressure wave that looks almost like kind of ETAC. And then as the catheter is advanced into the pulmonary artery, the amplitude of the signal goes down and you begin to see a dichrotic notch because, of course, you passed one of the major valves. And then when the cuff is inflated and driven from the pulmonary artery and then wedged into pulmonary capillary beds, you see something, again, that looks kind of like a CVP, except that the pressures are, of course, higher. So that's kind of what the waveforms look like. And this is just kind of showing you more what the waveform looks like. Again, slow VTAC is how some describe it. I don't like to describe it that way because people tend to think of art lines as if they're an EKG reading anyway. And remember, this is way different in that this is, you're actually measuring a pulsatile pressure, which is, of course, a real-time measure of perfusion. So that does actually make it pretty different. The PA waveform is definitely smaller, definitely has a distinctive dichrotic notch. That's really kind of the takeaway difference. And then the wedge, you would go from a PA to this. That would be a patient that's being wedged. Again, everything flattens out. It looks kind of like that CVP reading again, except your baseline is higher. So post-insertion priorities and transport, again, you would want to get a chest x-ray, make sure that the PA line isn't coiled or kinked, make sure that it's reading and producing faithfully on your monitor screen, get your initial set of vitals, and then off you go. So what are you going to get from your Swan-Ganz catheter? Well, a boatload of information. So you're going to get cardiac index, cardiac output. So cardiac output is the volume of blood injected from the heart with each contraction. Cardiac index is really sort of the one that we use. Cardiac output is not really used that much anymore. So CI is essentially cardiac output that factors in total body index in there. And so it sort of kind of takes out the really fat factor or the really skinny factor. So CO is 4 to 8 liters per minute. CI is 2.5 to 4 liters per minute. Things that cause them to be decreased. Cardiac output is decreased in low volume states, hypovolemia, cardiogenic shock, and late sepsis. Now remember, sepsis, this would be very late sepsis. This would be their dying sepsis, okay? Sepsis is usually hyperdynamic, so cardiac output doesn't fall until very late. Arrhythmias that are non-perfusing can produce a fall in cardiac output. Severe metabolic acidosis produces a fall in cardiac output, and then hypoperfused states produce a fall in cardiac output. Things that increase cardiac output or cardiac index, hypoxia, inotropes. Remember, early sepsis is hyperdynamic, so the cardiac index, cardiac output rise, and then renal failure and anemia. Again, all of these cause the cardiac index, cardiac output to rise. And so again, kind of a nice compare and contrast there for you. Pulmonary artery pressures, again, these are going to be measured when the pulmonic valve opens, and this is the rapid blood flow from the right ventricle into the pulmonary artery. Again, the norms here are 15 to 30. You won't really measure these as often. So things that increase pulmonary artery pressure are not as important as things that decrease. Notice what decreases a low volume status or hypovolemia. So if you have low pulmonary artery pressures, you have a volume problem, okay? Again, pulmonary artery diastolic pressure, same thing. You have a volume deficit if this is low. The norm here should be 5 to 15 on the diastolic side. So remember, when it is low, you have a volume deficit problem. Wedge pressures. This is an indirect measure of left ventricular filling pressures or preload. It's measured with the mitral valve open after the balloon is inflated, and the pulmonary vein is, again, approximately the same pressure that's in the left ventricle. The norm here should be somewhere in the 8 to 12 range. It's not, again, depending on the text that you read, there are some slight variants, but that's probably a general good rule of thumb. Things that cause a low wedge, hypovolemia, or right ventricular infarction. So why would right ventricular infarction cause a low wedge? Because with right-sided dysfunction, you have poor venous return to the left side of the heart, and that produces that relative hypovolemia, which is the reason we don't give those folks nitrates, because again, we can crater their blood pressure. So right ventricular infarction with right-sided dysfunction is actually a preload problem, and it actually presents initially with a venous return deficit, which is in fact a volume deficit. So consequently, in those patients, you would have a low wedge. Pretty much all the other pathologies, intravascular volume overload by mitral stenosis, left ventricular failure, cardiogenic shock, these are going to increase your wedge pressure. And again, we said the normal wedge is somewhere between 8 and 12 millimeters of mercury. Again, there is some disagreement depending on which text you read. You'll see as low as 4 to 12 or 6 to 12, but generally a low number, 12 or less, is considered to be the norm for a wedge. Now, I will tell you in transport, if they have, if you pick up patient X, so let me just say we don't put pulmonary artery catheters in at Apollo MedFlight. We might be asked to manage them in transport, but we don't put them in. So if they just wedged your patient, if you have a wedge pressure that's less than 2 hours old and there has been no significant change in the patient, you do not have to re-wedge them in transport, and unless you're given a direct order by med control or the sending physician wants you to re-wedge them. So many times what's happened is that we'll actually take the pulmonary artery catheter and we'll use the last wedge pressure we got from the sending, and then when we get to the receiving, we'll re-wedge them again and see how they're doing. Unless you have them a long time and unless you see some major change, you may very well not want to re-wedge them in transport. Again, wedging obviously is producing a very small pulmonary embolus. That's what wedging is. So there's a finite number of times that you can wedge any single patient. But again, it just does depend on the underlying condition and how unstable that they actually are. So another thing this one gives us is systemic vascular resistance. This measures afterload, again, applied to the left ventricle. This is the force impeding injection of blood out of the ventricle. It's a really important finding. It's measured in dynes per second per centimeter squared. The norm is 800 to 1200. So think about squeeze, okay? So systemic vascular resistance, you're able to measure squeeze. So what would decrease squeeze? Things like sepsis, anaphylaxis, hyperthermia, vasodilators, things that would decrease squeeze, things like true spinal shock. This would decrease systemic vascular resistance. So what would increase systemic resistance? Well, hypovolemia, hyperperfusion, the fight or flight response, right? Hypothermia, the use of pressors, cardiogenic shock, left ventricular failure. Again, those two probably go together. Left ventricular failure producing cardiogenic shock is the way that I would say that. But those would be things that would cause an increase in systemic resistance. So again, you get just a mountain of data with this device. So you should be able to devise a treatment plan, hopefully that keeps your patient who's obviously sick or they wouldn't have one of these. It should allow you to design a treatment program for them that should be the best possible one in transport. So some things you want to make sure that appear in your chart. I know all of us who get charts back from CQI, we moan and groan and we carry on, but there's some really important things those folks are doing out there to help us, document the right things, not only for the patient's sake, not only for patient care, and certainly, of course, because we, don't want to get sued, but because in the continuum of care, we need to make sure that we're giving the right information to the receiving hospital. So how many centimeters out is the catheter? We want to compare that to the initial insertion reading. We want to make sure it didn't move. What's the waveform like? What are the initial readings, particularly with regard to cardiac output and wedge? What's the site look? What type of dressing? What port is each med running through? And then was the line re-zeroed? Was it monitored during transport? Again, some complications that can occur. Blood in the tubing. If you have that, check your pressure gauges, check for loose connections, and verify that the stopcock did not accidentally get hit. If you have a system disconnect, you want to perform an occlusive maneuver to stop the bleeding, flush the device again, and get it working again. So if you see a bunch of PVCs, you want to put the patient on their left side, and if they can, have them cough. The interthoracic pressure changes from coughing many times will actually move the catheter if it's against the side of the ventricle there, or if the tube itself is actually causing some localized irritation. That pressure change can actually move it. And then, of course, initiate your antiarrhythmics. If there's an accidental dislodgement as evidenced by Y complex tachycardia, you may inflate the balloon to advance forward, but you never advance without the balloon. So if the VTAC remains, pull the catheter back to a 2 centimeter mark at the insertion site, and this converts it to a central venous catheter. Then you would discontinue your pressure tubing from the distal ports and switch the IVs from the proximal to the distal, which is now, of course, outside the body, and then just continue your infusions. So you would essentially just be turning it into, again, a central venous catheter. So that's kind of one of those kind of easy to do things when we're sitting here talking about this in a classroom. Much scarier to do when you're actually in an aircraft moving a patient between hospitals. So again, because of the information that you get from a Swan-Ganz catheter, man, you're able to just really take low perfusion states and sort of hone your therapies in. So again, because you can see pump failure, you can see volume failure, you can see resistance failure and septic shock, and you can see the loss of tone and alpha tone and stimulation in neurogenic shock, you're able to really see whether or not your therapies are being effective or not. So in terms of diagnosing cardiogenic shock, remember in cardiogenic shock, the pump is unable to overcome systemic resistance. So when you're looking at cardiogenic shock, sort of the classic presentation on a SWANS would be your systemic resistance goes up, your pulmonary capillary wedge pressure goes up, but your cardiac index goes down. So again, cardiac index goes down against systemic resistance and against volume. So consequently, the failure point there then would in fact be the heart muscle. Hypovolemic shock, that's really the one that I like to teach most, because volume shock is the one that you're used to seeing. You're used to seeing a hypovolemia. And in hypovolemia, all the things that you know, you can kind of count on. So like, for example, you can count on in volume deficits, the body wants to do the fight or flight thing, right? So systemic vascular resistance goes up because your body is putting more squeeze. It's trying to shunt blood away from the periphery to the core. Your wedge pressure goes down because wedge pressure is a relative volume indicator. Your cardiac index goes down because, again, there's not enough volume to perfuse all of the tissue, and your CVP, which is ultimately only a hydration status measure, it goes down. So again, the squeeze goes up with systemic resistance, and everything else goes down in volume shock. And sepsis, of course, is the one that doesn't really fit. So we put the parameters down here, but remember, when you're looking at a Swan-Ganz catheter and you have a low perfusion, profound shock state, and your readings don't make sense, you have to consider that the patient might be septic. Remember, even in the ED, even with all the tests that we have to diagnose sepsis, we still miss sepsis in ERs more than we catch it. It is still the thing that we do not catch because it is a hyper-metabolic state initially. So in sepsis, there's a failure to squeeze with a low blood pressure. Remember, that may be low relative to the patient's normal state. And so when you're looking at a Swan-Ganz catheter, your systemic vascular resistance goes down. Your central venous pressure, which indicates, of course, volume status, goes down, but your cardiac index, the effectiveness of the pump actually goes up. And again, that's that hypermetabolic state that we said in early sepsis, the heart is actually compensating for everything else failing. And that's kind of what gets so tricky. That's the reason in sepsis, the skin signs many times are actually pretty good, even though their blood pressure is very, very, very low, if it's measurable at all. And what I have found in my personal experience in sepsis is so oftentimes the clinical staff at the sending hospital don't actually believe their own readings. You know, you walk in the room and the blood pressure alarm is going crazy on the monitoring system, and the sending nurse is like, "Oh yeah, that thing isn't reading right. Yeah, I know it says the blood pressure is 60, but look, she's still talking to me, so she's okay." And sure shooting, you know, she's not okay. So anyway, and neurogenic shock, of course, depending on where the lesion is, the container, because of the loss of alpha receptor stimulation, the container gets really big below the level of the lesion. And with neurogenic shock on the pulmonary artery catheters, your systemic vascular resistance free falls, your central venous pressure goes down, your cardiac index goes down, and so does your PA numbers fall as well. So in neurogenic shock, the container gets big against this loss of tone. And so the other thing about neurogenic shock that's kind of telltale is, remember, in neurogenic shock, classically the skin signs are exceptionally good. Exceptionally good skin signs. The skin, the body doesn't actually recognize neurogenic shock. So your skin remains very well perfused with excellent capillary refill times, even though the patient in some cases may be dying from hypoperfusion. So just kind of a couple of really simple, kind of dumb case studies, actually. But you have a 65-year-old that's 2 days post-anterior wall MI. We know anterior wall MIs are those big, gnarly ones. She's tachycardic, again, classic find of anterior wall MIs, right? They're typically tachycardic. You have a systolic pressure of 85, diastolic pressure of 40, breathing 14 times on a ventilator at 80%. Your sats are at 94. Your cardiac output is 2.0. Your cardiac index is 1.8. Your SVR is 1800. CVP is 8. And your wedge is 20. So the question is, what's wrong with this patient and how do we treat it? Well, this is definitely cardiogenic shock, right? So again, we would definitely want to go to our cardiogenic shock protocol, and we would want to increase the squeeze of that myocardium, or decrease the systemic vascular resistance, or maybe, if we could, do both. So again, these are really simple case studies. Okay, y'all throw me a bone, but when we're teaching this initially, we want to make this information useful. So here's an 18-year-old admitted for nephritis, and of course tachycardic with a really low blood pressure, decent sats. Your cardiac index is really high. Your SVR is not so high, and your wedge and your CVP are both low. So in this case, obviously this is the one that doesn't fit. So you would worry very much here about sepsis, and you would, of course, start down the treatment pathway for sepsis in this case. So that's kind of the utility for using these things. Remember, the most important thing about a Swan-Ganz is recognizing that this is a really sick patient. So before you move them on your cot and start out the door with them, you want to make sure that you're comfortable that the Swan-Ganz is working, that you need to monitor it, get their last wedge, make sure you and your partner agree, okay, what the problem is. And then from that point in time, then you can kind of make an educated guess on what it is that you need to do in transport to deliver the patient to the receiving hospital in at least as good as and hopefully better shape than when you got there and you found them. So, all right, well, guys, I appreciate y'all letting me be a part. Ducey, thank you for allowing me to kind of help do some of this training, and I think there's a little quiz on the end here. So this is Chuck signing off.